Hey guys, welcome back to another episode of the Rick and Danny Show. We're excited to be here. How you doing, Rick?
I can't complain. How about yourself, Danny?
Doing well. Doing well.
I see you got some paperwork in front of you. I know there's a lot of, well, not a lot of, but I know there's one big trial that came out recently that is all the buzz in the health community. Pretty big deal. Kind of
Yep.
put into perspective long-standing practice for cancer screening.
That's right, Rick. The article you're referring to is a article looking at colonoscopy for screening for colorectal cancer. I can't say that I yet have done a thorough overview of the article, but I have reviewed it and I have some of the updated information here that we'll talk about. Basically, what this trial was looking at was looking to see if there's a mortality benefit in screening patients this was done in Europe, screening patients for colorectal cancer via colonoscopy. Now, the inclusion, exclusion, and how they kind of formulated the study, I don't have all the details of the methodology of the trial, but what I gathered from them was they kind of separated patients into two main groups. So they called it two main groups: the invited group, and then the other group was a group that kind of underwent normal care without a colonoscopy.
And I think this was over, 6 or 7 countries in Europe? Is that right?
Yeah, so it was done in I think Sweden, Norway, and Poland were the main
There's
countries.
3. Okay.
There
Yeah,
might have been a
I know it was
fourth,
multiple
but
countries.
it was.
Yeah, so the interesting thing I found about the method,
Mm-hmm.
the way it was set up was it wasn't a mandated colonoscopy. It was more
Mm-hmm.
you were invited to be screened.
Invited to, yeah.
So sort of it's our suggestion if you're in the interventional arm that you get a colonoscopy, but it didn't mandate
Mm-hmm.
that you had to do it.
Yeah,
And,
Norway, Poland, Sweden, yeah. Mm-hmm.
and they tried to, find out in the invited group compared to the sort of control standard of care arm, would there be any difference in survival? Would there be any difference in colon cancer
Mm-hmm.
mortality? Would there be any difference in outcomes that people would care about? So
Right.
I think that's kind of the setup. So a little interesting.
Yep.
For those who don't know, here in the United States, obviously it's guidelines for we've covered on previous episodes. When to get screened for colon cancer, and colonoscopy is one of the rare cancer screenings that allows for screening and treatment at the same time, potentially, in terms of, you can remove a polyp at the time. So it's sort of a
Right.
screen and a prevention intervention, which there's, not a ton of. So,
Right.
but yeah, this trial is trying to quantify it in a randomized fashion.
Yeah, so I think the positives of the trial are that it was a large trial. They had 85,000 patients who were previously unscreened for colorectal cancer. So the invited group was in a 1-to-2 ratio. So actually, there were more people not invited than invited. So twice as many not invited. But out of the invited individuals, the invited individuals had the option to undergo a screening colonoscopy, and then they followed them for 10-year outcomes. So they had multiple outcome variables that they were looking at. One, and the major one being mortality, over 10 years. So out of the invited group, now this is, as Rick said, you're invited for a colonoscopy, but you don't have to have a colonoscopy, so you couldn't force that group to undergo a colonoscopy. So only 42% of the people in the invited group accepted their invitation and underwent colonoscopy. So that's one of the, I guess, argued points in the study is that, we'll go over the outcomes of it, but, you'll have less than half of people in the, not treatment, but the randomized arm
I look at it two ways,
undergoing intervention. Yeah.
right? In one way, you're right. The downside is only 40%
Right.
did the colonoscopy. The counter is this is trying to be reflective of real world, right?
It is.
So right
yeah.
now we don't have 100% uptake in people who should be screened getting colonoscopy. I think I read estimates in the United States it's somewhere around 60% of patients. So obviously there's a difference between 40 and 60%, but it's reflective of kind of real life in that just because a patient should get screened or is recommended to get screened for colonoscopy, obviously 100% of people are not going to take those recommendations. So, depending on how you look at it, you can kind of argue it both ways, but the one thing I liked about kind of even though it sounds a little weird, invited style is it's trying to mimic, okay, well, if we invite people, what are the actual number of people that are going to do it? And then can that be applied, is that applicable to the real world?
Right.
Outside of a trial.
So their primary intent to screen analysis, and it revealed the following outcomes. So we'll go over kind of what they found. The incidence of colorectal cancer was lower in the invited group, and likely due to removal of precancerous polyps. So that makes sense. You have patients who underwent colonoscopy compared to people who didn't. And one of the main reasons to undergo colonoscopy is to find polyps, which are precancerous, and remove them. So not a surprising outcome there.
Yeah, and I think, do you have the absolute numbers there?
Yeah, right. So cumulative incidence of colorectal cancer was 0.98% versus 1.2%.
Right.
So overall, low.
Right. So for the audience, you when you look at this and you say, and you read articles like this, the hard part is depending on which side the person who's writing the article is on, you can kind of frame this one of two ways.
Right.
You could say that's what you could say is in absolute numbers. So if you said in percentages, it's not a big difference, right? What did you say, 1.2 versus
0.98.
0.98, right? So
and I'm going to bring up absolute numbers here just so we have them in front of us too.
Yeah. So if you're someone who is trying to say colonoscopies aren't important, you would highlight the low incidence of colorectal cancer in the two arms. If you're someone who is advocating for colonoscopies, you would say, you don't mention the low numbers, you say, but the relative risk reduction is significant. So what you're saying is that it's a ratio of the two numbers versus actually stating the two numbers.
Right.
So this is why I don't know who the quote is attributable to, but there's lies, damn lies, and statistics.
Right.
You can kind of get statistics to say, you can phrase them in ways that can kind of make your point on one side or the other.
Yeah.
So, what you as the patient are asking yourself is, is having a colonoscopy worth a half a percentage point improvement in colon cancer, free survival, which I'll be honest with you, for me, the answer is probably yes. But for someone else, it may not be. And so that's how I would frame a discussion with a patient is, this does improve your chance of not having colon cancer, but that difference is a tiny difference on the big scale in terms of numbers, but it does improve your benefit. So I always find these kind of things very, it's funny to hear the GI doctors talk about relative risk reduction, whereas the more medical conservative people are going to talk about, well, look how small the numbers are. Is it worth putting people through these procedures? So you can kind of argue it both ways. I don't know if you agree with that or not, but that's kind of how I always laugh when
I do. And I mean, I think the absolute risk reductions generally in our trials, in oncology trials, are much smaller than when we talk about relative risk reductions. I mean, and it sounds, I mean, even when you write a news article and you say this cancer drug led to a 45% lower chance of death or recurrence of disease, you're like, wow, 45% reduced risk of death or recurrence. But if that risk of recurrence is 5%, you're talking small beans.
And do you say, the GI doctor is going to tell the patient, if you get a colonoscopy, it cuts your risk of colon cancer death by 1/3, 33%.
Right.
I was like, holy smokes, that's a lot. I definitely need colonoscopy.
What's my risk to begin with?
It goes from 1% or 1.2% to 0.9%.
Right.
So you could frame it, depending on
of course
what you want. But so I think to me, what you have to do is tell patients, to me, you say it both ways, and then you let them kind of decide what's important to them.
Yeah. So risk ratio 0.82 for this. So you're talking 18% reduction, right? So that's the way of saying it. So,
sorry, I didn't mean to go on that tangent.
No, it's good. All right. Okay. Another, and I don't think it's written here. Let me just make sure. So another good thing to note is the number of patients needed to invite to undergo screening to prevent one case of colorectal cancer within 10 years. So you need to invite 455 individuals to prevent one rectal or colorectal cancer. Okay, so that's another thing that is brought up. We call it like you got a number needed to treat, or you talk about even in terms of harm too. You can bring up, depending on how you look at the study, if you're looking at a benefit, well, how many patients do we need to treat or screen or to have a benefit of doing it? So 455 was the number in this study. Okay, so colorectal cancer related mortality at 10 years was not significantly different between the two groups. Which, to be honest with you, if you look at an 18% improval or difference in the incidence of colorectal cancer, which isn't huge relative, difference, that the CRC or colorectal cancer related mortality was not significantly different. That's not too surprising. The mortality was 0.28 versus 0.31%, so pretty low percentages overall. And then all-cause mortality at 10 years was identical in the two groups, and it was roughly 11% for each group. And I did print out, actually, because I was interested in just knowing, one, I don't know what the incidence or risk of death of colorectal cancer in Sweden and Norway and Poland was, so I just printed out some data for us to go over here. Sweden, the incidence of colorectal cancer is 10.8%. And that actually is, I found it actually surprising. It was higher than U.S. It's at about 8% in the U.S.
That's interesting.
And then I think Poland was the other one I printed off, which was one of the groups that led to majority of patients, and theirs was 12.5%. So both were higher incidences than the U.S.
Yeah, it's the other thing I think that comes up with this argument is, there's some data, I think you would argue, older trials, but better data that FlexSig actually, there's been studies showing it. That's a flexible sigmoidoscopy where it's kind of like a colonoscopy, but they don't go all the way through the colon. They stop at kind of the rectum and the sigmoid colon, which is the two areas you're most likely to have, issues with. So there are data looking at that showing a survival benefit to FlexSig, a cancer-specific survival benefit. Nothing compared to, not colonoscopy, but compared to other ways or no screening. So there's some people out there now kind of saying, well, should we be moving away from colonoscopy and maybe towards FlexSig because the prep is less, there's slightly less risk of perforations. The procedure itself is not quite as invasive. I don't think they necessarily require general anesthesia like a colonoscopy.
Right.
And I think was a point I heard that was I thought interesting is that, when we do mammogram, someone said, well, if it's a FlexSig, is it like doing a mammogram on one side, because you're not checking the other side? Well, I think the counter to that is we would think both breast tissues are the same. It's not like one breast is different than the other, but we have a lot of data, and you can speak to this data better than I can because it involves your specialty more. Right-sided colon cancers are very different than left-sided colon cancers in terms of genetics, in terms of what they respond to, in terms of prognosis. So, we may not need to be screening that right side. Maybe those are just going to behave differently than kind of the other ones. So, just very interesting points that, I don't claim to be an expert in, but definitely were things I'd heard kind of as fallout from this article.
Right. Yeah, no, I think all of those are good points. I think that, another thing that they mentioned here was just looking at, because of the invited group only having 42% who ultimately underwent colonoscopy, they did a secondary adjusted per protocol analysis, which actually found some significance in terms of
intention to treat, if you will, not non-intention to treat.
So this was, kind of looking at a subset of just the patients who actually underwent colonoscopy versus the control group, and they found a more, or actually a statistically significant difference in mortality.
But even then, those numbers were super low, right?
Low generally, yeah. I mean, the mortality, just to review, was 0.28 versus 0.31% over 10 years, and it was 0.15 versus zero point 0.3. So that zero point 0.3 kind of remained stable in both analyses for the group who didn't undergo colonoscopy.
Right.
It was lowered in the patients who did to 0.15 from 0.28. But, I think we're talking about much smaller numbers, and again, they're the way they formulated the study initially was not to look. I don't think they. I don't know if this was a pre-planned or not.
Definitely not.
Analysis.
Yeah. Well, and you don't have the power calcs to. So,
Right.
but I think even then, when you look at it, it's statistically significant. But again, it's the same thing as before, where if you talk about relative, well, you say, oh, look, it cuts your risk of death in half.
In half, right.
But then someone says,
Right.
well, what are the actual risks of death? And you tell them the numbers,
Yeah.
they're going to go. So I think, because I mean, a colonoscopy, I've had one. It's not without, you have to do prep.
Mm-hmm.
You're basically out for that day. So there's some economic production loss. You can't work. It's not, I wouldn't say it's a very tough procedure to have, but it's not a,
Yeah.
in and out within, the same day,
Yeah.
kind of thing. So, I guess everyone's going to be different in what they value in terms of,
Mm-hmm.
is it worth doing all that to have a colonoscopy to prevent 0.15 risk of death?
Right.
To me, if it was me personally, yes, but someone else might not feel that way.
Right.
So it's just it'll be interesting to see how this gets incorporated, if at all, into, national guidelines. Because we just lowered the age of colonoscopy screening here in the U.S., which obviously this trial may argue against that. But I do think
Right.
there's clearly an incidence of, especially rectal cancer, that's rising in young people here in the U.S. So how do you balance all that with this? And I think there's other trials that are still, undergoing follow-up right now that are looking at similar questions of colonoscopy versus FOBT, colonoscopy versus the FIT, colonoscopy versus, other ways to screen for colon cancer.
Yeah. Complications from colonoscopy, which you kind of alluded to, happen. They're uncommon, but they happen, and major bleeding being one of them. If you, for example, remove a polyp and have major bleeding after a polyp removal, they saw 15 cases of major bleeding in 20,000 screening colonoscopies. So low incidence of major complications, but they're real. I mean, I've seen complications after colonoscopy. So I think patients obviously need to be counseled on that before they undergo screening colonoscopy. I think the last thing I'll say is that, the follow-up of 10 years, is that also the appropriate, duration of follow-up for something like this? I think things may change over time for studies like this, because you have patients who had screening colonoscopies, had polyps detected, and need surveillance following that. And so their risk of colorectal cancer possibly could be higher than individuals who don't have any polyps. And so over time, we'll see if that changes. I don't think they're going to see much of a difference in mortality.
Yeah, I feel like with as low the numbers as they are,
Yeah.
it's going to be hard.
Yeah.
I would be surprised, as you said, if
Right.
there's going to something's going to get teased out with more time.
And is mortality the right thing to look at? And that's a big question too, even for like PSA testing, right? Mortality, is that the right outcome? Because certainly, undergoing cancer treatment has its big negatives in terms of morbidity.
Well, and I mean, to me,
quality of life.
To me, the barrier of a screening test should actually be more than even a cancer treatment. And the way I look at it is, you're taking presumably healthy people and screening them.
Right.
So you have to be pretty darn confident in whatever you do, that I'm taking this healthy person in front of me and I'm going to make things better for them. Versus someone with cancer, that you at least say, yes, obviously you look at the same things, that you wouldn't give someone a treatment if it wasn't going to help them, but they have a problem that in some cancers, no, but in most cancers need to be addressed because the cancer is a competing risk factor for their life expectancy. Versus in this situation with the screening, these are healthy people, and if
Right.
you find things and they enter the medical, get on the assembly line of procedures and tests and things, you have to be pretty confident that what you're doing to screen them is going to help them in the long
Right.
run. And so I think, to me, it's tough because me personally, how I feel is the barrier to entry is actually greater because you're you're taking otherwise, presumably healthy people
Right.
who don't have any medical issues.
So would you have mortality as the endpoint here?
I think ultimately
appropriate?
what people care about is mortality, right? In the long term. Like, if you could tell me a screening test makes me live longer, that's a pretty good screening test, right? I think that would be the biggest thing. Now, if you said this screening test makes me prevents me from getting a cancer and helps me live longer from this cancer, to me, for me personally, I would be on board to do it. If you tell me this test may or may, doesn't, then
yeah. I think, I do think though the news, and especially from the medical community, should be that this is the data in terms of prevention of, or what the difference is in incidence of colorectal cancer in the two groups, independent of mortality, and then look at the mortality, and people can make up their own minds the significance of that.
Exactly right. And that's why I
Right.
said, to me, when you talk with it, if it was me in a primary
Right.
care office talking to a patient about whether they should get a colonoscopy or not, for someone who's, of course, if you're high risk and all that, yes, you should get one. I think that data is pretty clear. But in a otherwise no risk factor patient, to
Right.
me, you say your risk of dying from colon cancer is really, really small either way, but there may be a benefit in colon cancer specific mortality if you take a colonoscopy.
Yeah.
I would take that test. I already have. I've had a colonoscopy, but some people may say the prep. I don't want to deal with that. Like, everyone's just going to be
Right.
different about it.
Right.
So
Yeah. And with more non-invasive tests coming out, I mean, we'll see how things go.
yeah, it'll be interesting to see if that, because obviously then the argument of the risk to the procedure goes way down. But yeah, it'll be interesting to see if those tests can achieve similar outcomes to colonoscopy.
Yeah.
That was a good discussion.
Good discussion.
Productive. I like it.
It's really
Brenna, any questions on any of that?
no.
So you can get your colonoscopy?
I'm only 26.
To be determined.
You got many decades.
By
ahead
that
of you.
time, they'll prick your finger and they'll tell you
Oh, yeah.
you need one or you don't.
Yeah, by the time you're exactly right. Just take
Or
a
just
pill.
scan you.
Yeah.
It'll just take a pill. It'll fix everything. Well, thank you all for tuning in for another episode of the Rick and Danny Show. We appreciate your attention and for putting up with us for another 20, 30 minutes.
Thanks, guys. Talk to you soon.